Okay, sir. So, good evening, everyone. I would like to welcome Lazar sir. He's been a very important teacher in our society and all academic programs. He's been a very active member. So, like, it's our privilege to have him here to talk on malignant bone tumors. So, hope we'll have a very good interactive session. Please feel free to interact. You can ask questions, or you can put your questions on your chat box and we can discuss it here. Over to you, sir.
Good evening to all of you who have gathered there. Today I'm going to talk on malignant bone tumors, and the objective of this talk would be how to diagnose a malignant bone tumor, the very basic things, how to investigate, and the general management of malignant bone tumor. I'm not going to confine to any specific bone tumor. I'm just going to give a overview of malignant bone tumors and how to proceed. So if I can ask somebody, what do you mean by a bone tumor? Can somebody answer what is a bone tumor? No, I'll have to tell you all that you have to interact. Otherwise, I'm just going to go ahead because I don't think we'll have time to complete the whole thing. This is not, picture and question session. So I'm putting in a lot of material for you to read also later. Can somebody say what is a bone tumor? If not,
it's an uncontrolled.
Gautam, yes, Gautam, you are there.
Yeah, sir.
Don't look into your don't look into your internet.
Sir,
this fellow can get internet within seconds. Okay, right. Tell me, what is bone tumor?
Sir, a tumor that involves the bone, whether it's a malignant or no, sir,
okay.
Sir, abnormal growth of the bone cells, osteoblast, osteocyte, osteoclast.
Abnormal growth of bone cells. So, as a definition, we put it as the okay. Bone tumors develop when cells within a bone divide uncontrollably. Uncontrollably, that is the word. Forming a lump or mass of abnormal tissue. Okay, so this is now divided into two groups. One is benign and the other is malignant. Now, can you define benign and malignant? Anybody? We are using these terms very, very casually every day.
Yes.
Benign tumors don't have the capacity for metastasis and they remain confined to the immediate periphery, whereas a malignant tumor have a capacity to metastasize to a distant site other from the immediate periphery.
Very good. So a benign tumor is one which remains localized as a localized mass and often cause pressure effects. It may cause pressure effects on the surrounding tissue. Whereas a malignant tumor means that the capability of that tumor to invade normal tissue either locally or at a distant site, that is via blood or lymph. So that is the difference between the benign and malignant tumor. And in diagnosis, you have various steps in the till you reach the final diagnosis. Again, this is very important. A clinical diagnosis is important. Now, once you finish your clinical examination, don't look at the X-ray or MRI before you touch the patient. This is very important because you must have an idea what this is about. So the clinical diagnosis first, and then when you order the radiology, you must have a radiology diagnosis. And then when you order relevant laboratory investigations, you must have a diagnosis till that level. And the next will be probably an MRI. If you require that, again, at that level, you should have a diagnosis. And then a CT correlation may be required for certain tumors. At that level, again, a diagnosis with the help of the radiologist. And then a PET scan, maybe, these days PET scan is done left and right, so it has its usefulness. So whenever that is indicated, you have to get another diagnosis after that, and the bone scan if necessary. And then finally you have a histopathological diagnosis. That is the final diagnosis, which includes the immunohistochemistry. And then after all these things, you get a final diagnosis, and that is the diagnosis. So at each level, you should keep on if your clinical diagnosis is right, you can continue with that, or you have to change your diagnosis as you get your investigations. So the clinical diagnosis will be a detailed history. I'm just emphasizing on this again, because the first thing when a patient comes to the OP is to get hold of the MRI or the X-ray and look at it. So you'll miss a lot of things if you don't take a detailed history. The age of onset of the disease is important. Which bone is affected is important. Are there any constitutional symptoms? The pain, intensity, type, aggravating and relieving factors, and night pain. Swelling, again, the rate of growth in relation to pain, the swelling, in whether the pain came first or the swelling came first. In many tumors like osteosarcoma, you find that the pain came first and then later the swelling. The rate of growth, if it's a benign tumor, again, the rate of growth is very slow. Whereas in a malignant tumor like an osteosarcoma, you find that he comes with a swelling within, a few weeks or months. Then the site, shape, size, surface, plane of the swelling, and whether the patient has any limp, when he is limping, why he is limping, has he got pain on walking, and does he have any signs of neurological deficit like a high stepping gait. It's not over there. Then you have to examine the lymph nodes, thyroid, breast, liver, spleen, pelvis, hip, all these things, and the spine, hip, knee, and the popliteal fossa. All these things have to be looked into in a case of bone tumor, which is very, very important, again, because of the areas of metastasis, etc. So one of the important things is the age at which the patient presents to you. Can anybody say some of the ages to which a patient can present to you and what you infer from that? Anybody? So it's based on the history, physical findings, and diagnostic studies. The age, before the age of 5, a malignant tumor is often metastatic from a neuroblastoma. Between 5 and 15, I'm just talking about the common things, osteosarcoma or Ewing sarcoma, and after 40 years, metastasis or myeloma. The important thing is age is a very important factor in diagnosing bone tumors. Then comes the placement of these tumors in certain age groups. If it's less than 30 years and more than 30 years, there are certain tumors which are common in children, whereas some are more common in the adults. So depending upon the age again, and you have some idea about what these tumors could be. So this again, we just said that. The risk factors for malignant bone tumors. Anybody? So when you have a bone tumor, you must think about certain conditions. Yes.
Radiation histories.
Yes, history of radiation.
Then genetic. Family
Genetic.
history of
Which one is the genetic ones?
Neuroblastoma.
Pardon?
Neuroblastomas.
Neuroblastomas. What is the genetic connection there?
Neurofibromatosis, sir.
Pardon?
Neurofibromatosis.
Neurofibromatosis. Neurofibromatosis. It's part of a syndrome, is it? So these are the genetic disorders which are commonly associated with the malignant bone tumors. They are the Li-Fraumeni syndrome and the Rothmund-Thompson syndrome. These are theoretical things. I mean, I don't think we see these things, but then in your exams, maybe it's important. Then, of course, if you have a retinoblastoma in a child, then you expect, again, bone tumor. In a Page's disease, that's very important. Again, it's not very common in our country. You can get a chordoma or an osteosarcoma. Radiation, somebody said. And then bone marrow transplantation is associated with osteosarcoma. So these are some of the risk factors which you should be able to elicit in the history. So regarding Li-Fraumeni syndrome, they develop several types of cancers, including breast cancer, brain cancer, osteosarcoma, and other types of sarcoma. So these are mainly because of a mutation of the P53. Tumor suppressor gene, and some are caused by this CHEK2 gene. So these are theoretical things which you have to keep in mind for your exams. The Rothmund-Thompson syndrome. Children with this syndrome have skeletal problems and rashes. They also have more likely to develop osteosarcoma. This syndrome is caused by abnormal change in the gene REQL4. So just for information. Now we have reached a stage when you have finished your history taking, your clinical examination, and now you must have a diagnosis or at least a differential diagnosis. So after that, the first the investigation that you will order is probably an X-ray. So when reading the X-ray, what are the things that you would like to read? What are the points that you would like to look for?
Site, which bone is involved.
Yeah, you go in that order. You want to know which bone is involved first of all, isn't it?
Yes, sir.
The mature or immature skeleton, sir?
Yes. So immature skeleton, that is the age that we already talked about, the age.
The location of the tumor.
Then location in the bone.
Yeah, location in a bone.
So
just like you have in trauma, you have which bone, which location. You have one for humerus, one for proximal end, like that. So the location in the body, that is which bone, and then location within the bone, that is where do you classify that as? Within the epiphysis, metaphysis, or
epimetaphys and diaphysis.
Diaphysis, or it could be epimetaphysis, the combination of these, anything. Then what else would you look for?
Number of lesion is solitary or multiple lesion.
Yes, then you look for the lesion as such. In the lesion, you will see the morphology of the lesion. Then
Type of lesion.
Cortical destruction.
Yes, the morphology of the lesion includes cancellous bone as well as cortical bone. So in these two areas also you have differentiation. Then you have the zone of transition, which is again important. Okay. And you have to look for the matrix of the tumor, the periosteal reaction, the size of the tumor, and cortical involvement. So these are the, in order you have to check what are the findings in these. Right. So this is in which bone, which is the most common tumors. You can get few of those. At least the malignant tumors, you must know where they are located. And then location within the bone is epiphyseal, metaphyseal, and diaphyseal. That in the longitudinal. And then you must also see which tumors are central, which tumors are eccentric, or which tumors arise on the cortex. So this again, both in the longitudinal as well as in the transverse plane, this is important. So you can get some tumors which are in the epiphysis, metaphysis, and diaphysis. The malignant ones are the GCT in the epiphysis, metaphysis region, the osteosarcoma, chondrosarcoma, and fibrosarcoma in the metaphysis. In the diaphysis, you have the Ewing sarcoma, multiple myeloma, adamantinoma, and metastasis. So at least some of them you can remember. The most common ones you can remember: epiphysis, metaphysis, and the diaphysis. Okay. This is all together the benign and the malignant ones. You can go through that later. So as I told you, in the transverse plane, again you have a differentiation. That is, in the central part you can get the enchondroma. In the eccentric regions, GCT and chondromyxoid fibromas are more eccentric, and the osteosarcomas are usually eccentric. It can be central also, but they are usually eccentric. Cortical, they are the osteoid osteoma or the non-ossifying fibromas, and the periosteal osteochondroma and periosteal osteosarcoma. They are eccentric. They are from the cortex itself. Okay. So the analysis again of the lesion. You must know the pattern of bone destruction, the size, the shape of the lesion. We talked about matrix, trabeculation, periosteum. The margin of margins, the zone of transition. The margin. What is the zone of transition? Can you say? What do you mean by zone of transition? Everybody talks about zone of transition. What is the zone of transition?
The region between the normal bone and the neoplastic
Yes.
tissues.
So the line between, or the area between the normal and the abnormal bone is known as the zone of transition, and that which is seen on the X-ray, of course. And slowly progressive process is walled off, sort of, and they can produce distinct margins. That is also known as narrow zone of transition. Okay, this is again, you have to say these words in your exams. There is a narrow zone of transition, or if it's a rapidly progressive process, then it's a wide zone of transition. So narrow zone of transition and a wide zone of transition. Then, for example, this is a typical example. So, so can somebody say what this is?
Giant cell tumor.
Yeah.
Yes.
On the left.
Aneurysmal
On the left, there is a very narrow zone of transition, isn't it? There is some amount of cortical break here, but there is a well walled off lesion, both sclerotic as well as lytic. So this could be a more benign sort of tumor, a chondromyxoid fibroma. And here you can see the zone of transition, which is wide. The normal bone, you cannot, it's somewhere there. Understand? And there is a large lytic lesion there. The cortex is thinned out, it is broken in parts, and it looks aggressive. So this could be a malignant tumor, probably a giant cell tumor, or I mean metastasis, or osteosarcoma, or any of these things you can get in this area. So the bone destruction in tumors is because of osteoclast resorptive activity, and this shows the intensity of bone involvement, the aggression of the disease, and ability of the host to repair the bone. So the destruction of the cortical bone is seen more easily because there is a great contrast density there. Whereas in cancellous bone, you have to have at least 50% of bone loss before you can distinguish clearly the lytic areas. And the spine, you have, when one single pedicle is destroyed, you have the winking owl sign. So this is what I said in the very benign lesion. There is the margin is well differentiated and a very narrow zone of transition, and sometimes you have a a sclerotic line in between. So these are named as geographic. Anybody can say what they are? The destruction and the pattern of destruction. It's a classification.
Geographic, moth-eaten.
Moth-eaten and permeative.
Moth-eaten, geographic, moth-eaten, and permeative. And geographic can be further divided into
A, B, and C, sir.
yeah.
With sclerosis in the margin is A.
Yeah, sclerosis in the margin.
With no sclerosis in the margin.
Without sclerosis in the margin
is B. And
Ill-defined margins.
with ill-defined margins.
Ill-defined margins. So that is the way in which that has been, and biologically this aggressiveness goes from 1A, B, and C. So this is the one with the sclerosis in the margin, and it can be either a non-ossifying fibroma or a bone cyst, enchondroma, all these things. The second one is B, is that there is no sclerosis around the margin, but there is a distinct area of a narrow zone, and these are also usually benign. Okay, the normal trabeculia are reaching up to that area of destruction, and example for that is a giant cell tumor. The one C is a ill-defined margin. So here you cannot say where the margin ends, just like this tumor here. So it is a focally destructive but locally infiltrative also. So it goes on spreading from, in a haphazard manner, and so the zone is of the margin is very wide, and these are you can get that in again in GCT, fibrosarcoma and chondrosarcoma, etc. So many of these things, tumors have common features, but you will have to main things find out whether they are benign and malignant, and there are some specific features which are related to many of the tumors, the common tumors. Then you have the moth-eaten bone destruction, which is more aggressive. You have patchy areas of bone destruction and a larger zone of transition, and it consists of multiple scattered holes that may vary in size, and it arises separately, and they may coalesce to form larger bone destruction. So that is the moth-eaten appearance. And then you have the they are seen in Ewing sarcoma, fibrosarcoma, osteosarcoma, and these are quite aggressive forms of bone destruction. And the third is as you said, the permeative bone destruction. Again, there is, the aggression is much more, and there's a wide zone of transition, and you can see that they tend to infiltrate the marrow space, and some of these, although they look malignant, you must rule out an osteomyelitis, which is also can look very permeative in certain advanced cases. The combination of patterns, sometimes we get a combination of all these things, a geographic with the moth-eaten and a permeative pattern, and this indicates a change towards more aggressive local growth, because there is the aggressiveness of the tumor, you can say by looking at this pattern of destruction. Now, just like the cancellous bone, you have cortical involvement also, and the aggression and pattern of cortical involvement determines whether the lesion is aggressive in nature, whether there's endosteal scalloping, and whether there's a risk for pathological fracture. So you must check both the cancellous bone and the cortex bone. And here you can see. So what are these known as? Inside the this thing there are small.
Endosteal scalloping.
Yes. These are known as endosteal scalloping. So there is a resorption of the inner layer of the cortex and of the long bones mainly. And if there is scalloping of less than 1/3 cortical thickness, it is benign. And if it's more than 2/3 cortical thickness, it is malignant. So sometimes in chondrosarcomas, you may have to, it's very difficult to define whether it's benign like an enchondroma or a chondrosarcoma. And one of the things that you look for is a endosteal scalloping. So this is a picture of endosteal scalloping. Then the other is a lesion that can happen in the cortex is from outside in. There is an erosion, and this is known as saucerization. This because of the tumor which erodes on from the outside to inside, and this is known as saucerization. So, and the periosteal osteosarcoma and Ewing's tumor are examples of that. Not the parosteal, it is a periosteal osteosarcoma. So here's an Ewing sarcoma which is supposed to be showing this saucerization. So again, the next is then an expansile ballooned. So because of the destruction of the endosteal cortical bone, there's addition of new bone on the outside, which occurs at the same rate. And then because of this, there is an expansion of the cortex. So this can be either smooth or uninterrupted, but may also be focally interrupted in more aggressive lesions like GCT. So in GCT also, you can see that the bone is expanded. Usually they are eccentric, so they are expanded onto one side only. So can you read this X-ray, one of you?
Naomi, please read the X-ray.
So this is an X-ray showing the showing distal femur of a skeletally immature patient.
Yeah.
With a lesion in the metadiaphyseal region.
Yeah.
The distal femur. It's a geographic type of lesion.
Yes.
And the matrix has got both sclerotic and lytic. Matrix is both sclerotic as well as lytic type.
Yeah.
And with a narrow zone of transition, sir.
Yes, it is a narrow zone of transition because you can see normal bone just immediately after that.
Yes, sir.
Yeah.
And there is no associated periosteal reaction.
Yes.
No pathological fractures, and there is no other extraosseous component.
Okay. So, what do you think? This is a benign or a malignant one?
So it could be a benign, sir.
Benign. More likely to be a benign one. And do you have a diagnosis for this?
Non-osseous fibroma, sir.
Yeah. Okay. You can one of those non-osseous fibroma, or there's some amount of myxoid material also, maybe a fibro myxoid.
Okay.
So basic thing is that it looks more chondromyxoid fibroma. This is looks a benign one because of the narrow zone of this thing. There's an intact cortex, though there is some erosion onto the cortex. The cortex is intact, and as you said, all these findings are correct. There's no periosteitis. and there's no soft tissue mass. It has not breached the cortex. And what about this one? Gautam?
So this is the skeletally, this is a distal femur of a skeletally mature child person with lesion in the metatarsial lesion with sclerosis around the margin, and there is involvement of this soft tissue, I think. And there is a cortical break on the lateral side.
Yeah.
It's like a malignant lesion.
Yeah, more. What is the matrix like? Matrix is again so what are the three types of matrix you can look for? One is a fibrous one.
Calcified.
One is a calcified one or osteoid with mixed osteoid, and the other is a chondroid, isn't it?
Yeah.
Yeah. So obviously there are no areas of calcification, so it's not chondroid in nature. It's more looking like a and the zone of transition, did you say?
So it's a wide zone of transition.
That's a wide zone of transition. So what do you think this is? Possibly
Malignant variety.
malignant one. So there is periosteal elevation. You didn't say that, did you?
No, so I can say.
Yeah, there is periosteal elevation also here, and there is soft tissue extension, you said. Okay. So matrix again, as I just said, it's different types of mineralization patterns, and it could be a fibrous, osteoblastic, like it's known as cumulus cloud in osteoblastic, and fibrous ground glass, like in fibrous dysplasia and chondroid. And here also there are certain definitions: popcorn or arcs and rings and dots. So, and the common thing is chondrosarcoma. Periosteal reaction, the classification is benign versus aggressive periosteal reaction. So if it's a low-grade chronic irritation, then it is a thickening of the cortex only. It looks like a thickening of the cortex, and the cortex will be thick and dense. Whereas in aggressive one, you have a lamellated or amorphous or sunburst-like appearance. In different, most commonly seen in Ewing sarcoma, osteosarcoma, and the periosteal reaction in a benign lesion is a solid one, in laminated in aggressive lesions, and this Codman triangle is indicated of a more rapid area of growth, which what happens is that when the periosteum is elevated, bone gets formed in the area between the periosteum and this elevated and the cortex, and that's the reason for the Codman's triangle. And because it is more aggressive than a lamellated type of a periosteal elevation, it the soft tissue goes through the middle part of it. So only that angle which is ossified will remain, and that triangle is known as the Codman's triangle. So this is the picture of a periosteal reactions. So this is a periosteal reaction which is solid, usually getting in benign. This is a lamellated type when more aggressive, and you get a spiculated and Codman's triangle in when there's very aggressive reaction. The size of the tumor, again, you have to check when this you will get only by repeatedly taking X-rays. You can assess the interval change, and also there are certain tumors which have a similar histology, like fibrous cortical defect and non-ossifying fibroma. So if you see the size of the tumor, you can differentiate between a fibrous cortical defect and a non-ossifying fibroma. Fibrous cortical defect is smaller, non-ossifying fibroma is larger. Then these are the features of benign and malignant lesion. We said just now all that: well-defined sclerotic border, lack of soft tissue mass, solid periosteal reaction, and geographic bone destruction. Whereas in a malignant lesion, you get interrupted periosteal reaction. As I told you, the reason for that, the soft tissue bone destruction happens, and it happens at a very fast rate, so that you have the Scodman's triangle here. And you can get the soft tissue mass outside the bone and the wide zone of transition. All that is for malignant lesions. So MRI is the next investigation that we will look for, and it gives a better soft tissue study. And there are certain enhanced studies like dynamic contrast enhancement MRI. The main thing is after chemotherapy, like for osteosarcoma, once you give neoadjuvant chemotherapy, that is chemotherapy before surgery, then you would like to know the response to chemotherapy. And so for that you use contrast enhanced and then MR spectroscopy for molecular characterization of tumors, and this DWI.
Diffusion weighted imaging.
Diffusion weighted imaging in assessing tumor response to therapy. Again, these are specialized studies of MRI, which gives you ideas about these the response to chemotherapy and the molecular characterization. CT again remains superior to MRI in detecting the characterization of matrix mineralization. So here we can know better whether the matrix is chondroid or fibrous or other ways. So this is CT is very useful, and also the cortical involvement, whether that is ruptured or not, the cortex is given way or not, is very important, and the periosteal reaction. And most important is the detecting of pulmonary metastasis. So when you have a malignant bone tumor, you would like to know whether the bone is the tumor is metastasized. We can also do bone scan and PET scans. So PET scan is useful in the evaluation of metastatic diseases, and so it shows the accumulation of, in skeletal lesions of this glucose and FDG. That's the dye which they use, and they can say whether, depending upon the uptake, which all areas are involved. So tumor workup also includes the hematology and biochemistry for metastatic lesions, metabolic lesions, and infective screening, because the tumor may, mock any of these things. So you have to do a metabolic and a metastatic and the infective screening. You must also always take into consideration that this could be a infective pathology. So here now again, this is the area where you make another diagnosis, and then you go for the final diagnosis with the biopsy. So how would you do a biopsy? How would you do a biopsy? What are the things that you will keep in mind when doing a biopsy?
Yes, Shyam, please answer. Shyam?
What are the types of biopsies?
Please answer. Shyam?
Open biopsy, excision biopsy, and incision biopsy. And
open biopsy?
Open biopsy and closed biopsy.
Yeah, closed and open. Yeah, enclosed.
Enclosed through biopsy.
FNAC, throughput biopsy.
Corneal biopsy excision
Yeah.
site.
So why do you want to biopsy?
Confirm.
To confirm your clinical
If,
diagnosis.
if it's a malignant, we have to go for more radical procedure.
Yeah. So for confirm the diagnosis, to plan your management, for all that, and to go for immunohistochemistry, for all that you need a biopsy system. And before you do a biopsy, you will definitely look into the coagulation studies, CBC and platelet studies, because it may bleed, so which you will be then have a problem. So before you do a biopsy, even if it is a FNAC or a true cut biopsy, always look at the coagulation parameters. And of course, you will have a cross-sectional imaging also. So biopsy techniques are open, closed, fine needle, core biopsy, and all these things should be best done under image guidance. That's a very important thing. We most of the time now use either ultrasound or CT as a guide to do your biopsies. So which is the ideal site now in the following case of malignant tumor? Which is the ideal site for doing a biopsy, A, B or C?
C.
C. Anybody for any differing opinions?
B, sir.
B.
B for ball.
In the reactive zones also.
Yeah. So which is the active zone?
B.
B.
B, sir.
Yeah. So if you take a biopsy from A, it will be a normal bone, most probably. If you take it from C, you may get some necrotic bone. So the ideal place to take a biopsy is from the junction of the bone and the normal, the tumor and the normal bone.
Periphery.
Periphery, yeah. Junction and normal tumor bone. So now there are certain criteria for biopsy that it's ideally done by the surgeon who is going to do the definitive treatment.
Yes.
Or at least if you want to do the biopsy, discuss it with somebody who is already, a oncosurgeon or somebody who is doing this regularly. The path selected for the biopsy should be in the same line as definitive operation, because at that time the biopsy tract can be excised. The biopsy tract should avoid contamination of joints, uninvolved structures, neurovascular bundles and bones. And preoperative planning is absolutely essential. And if you're planning on a flap after that, you should see that your biopsy will not go through the planned flap. So all that is very important. As far as possible, transverse incision should be avoided. Why?
If we plan to use the same incision for surgery, it will be very difficult as to excise the whole tract in the transverse incision.
Yeah, maybe. Yeah, that is one thing. And the second thing is that it's in the, against the movement. So if you want to move your joint again, if it's a transverse incision, it is more difficult rather than a longitudinal incision. So transverse incision is best avoided. Then before doing, difficult problems, you can also ask the histopathologist regarding the type of tissue and all that. And if you're doing a frozen section, inform the histopathologist early so that they can be ready for it. After the open biopsy especially, you must have meticulous hemostasis, and tunicate should be released, and hemostasis should be achieved. You can put a suture mark over the skin entry site, because later when you come for definitive surgery, this point, FNAC point may have disappeared. So staging of tumors. Can somebody say how to stage tumors? So it's basically the staging is on the Anakin staging. Okay. So it is depending upon whether the tumor is intracompartmental or extracompartmental. Intracompartmental is A, extracompartmental is B. Then you also should know whether it is a grade of tumor. Grade of tumor is by histopathology. So if it's a high-grade tumor and intracompartmental, it is stage 2A. And if it's a high-grade tumor in extracompartmental, it is grade 2B. And if there is metastasis, it is stage 3 or high-grade metastasis. Now, this is the original Anakin staging. Do you know of any other staging? So now this is the Anakin 1. This is the American Joint Committee on Cancer Staging System. So they have modified the Anakin into 4 and 4A and 4B. And that is depending upon the mainly the N1, that is the regional lymph node metastasis. And here it is M1, that is distant metastasis. So in the regional metastasis, it is 4A, and in distant metastasis, it is 4B. So I don't know whether it, we need to be too much about that. Again, this is before 2003, and after 2003, they have again modified it. And this is how it goes. So those of you who are interested, you can go and check on these gradings, because you must know at least that they have been upgraded onto these. 2 more have come out based on the Anakin. So treatment of bone tumors. Overview with time 8:55. So the management generally is chemotherapy, radiation therapy, surgical management, targeted therapy, and the nursing management, which we won't talk into too much. So the chemotherapy is drugs used to kill cancer cells, and they receive a combination of chemotherapy. The most commonly used drug in this thing is doxorubicin and cisplatin, but there are a lot of drugs which are used in chemotherapy: carboplatin, etoposide, ifosfamide, cyclophosphamide, methotrexate, vincristine, doxorubicin, and cisplatin. So at least some of these names you should know, and where it is being used. They are used usually in combination. And then radiation therapy. It involves the use of high energy X-rays to kill cancer cells. It is used in combination with surgery if the tumor is radiosensitive. And all these things, mind you, now they are using it in combination with surgery. The advantage of radiation therapy is that it reduces pain of this cancer, and it decreases the chances for bone fractures. Types of radiotherapy: there are intensity modulated radiation therapy, IMRT, proton beam radiation, and high precision radiotherapy, therapy using computer controlled linear accelerator. Surgical management. This is where we are more interested in. One is prophylactic fixation in cases where you need to support to prevent fracture. Then the removal of entire tumor with negative margins, local excision, amputation, disarticulation, reconstructive surgery, and limb salvage. So, can you say something about prophylactic fixation? How do you decide on prophylactic fixation?
Based on the
Based on?
Mirel
score.
Yeah, Mirel's criteria. What is Mirel's criteria?
There's 4 variables: height, pain,
Yeah.
lesion, and size.
Yeah.
If it is score is greater than 8, we will go for prophylactic fixation.
Okay. More than 8, you go for prophylactic fixation. Okay. So this is the case of a doctor who had multiple myeloma. She was initially diagnosed with the nephropathy, and then they investigated and found that she had multiple myeloma. And on X-ray, she had I don't know whether you can make out. There are lytic lesions here, and in both the neck of femur and in the shaft. Maybe this is a little more this thing here and here. And she also had lesions in the humerus and the skull, a few lesions in the skull. So the trochanteric area is a very vulnerable area for fracture. So we suggested that she has a fixation, but then they were taking time for decision, and in the meantime the left one fractured. So we had to fix that, and then along with that they agreed for a prophylactic fixation on the right side also, and she's still walking around with those two implants. So this is the Mirel score, the risk of pathological fracture through metastatic lesion, and as you said, these are the things. The trochanteric area is the most vulnerable one, and the 9 is the palliative fixation, whole body palliative risk of pain relief. 8 is 16% and 7 is low risk. So types of surgical resection, can you define these? What are the types of surgical resection?
There is radical resection.
This is again a very important question. How do you resect if there is a tumor?
The intralesional is when the resection is done within the lesion itself.
Yeah.
Marginal is a very small cuff of normal tissue we can take along with the lesion. Wide resection is when we take out the whole muscle along with that, and the radical is the whole compartment of the muscles we take along with the lesion.
Yeah, this marginal means you should not touch the capsule or pseudocapsule of the lesion, because if you touch it, then it becomes a intralesional. So marginal, it is just outside the capsule, and wide resection is that you have to go at least 3 centimeters around the whole area, and the whole muscle should be excised. And radical resection is that the whole thing is, the whole compartment is, muscles are excised. So here in intralesional, or what you call as debulking, you have 100% recurrence rate. Whereas in marginal, it is 25 to 50%. En bloc resection with normal cuff is 10%. Then the other surgery that you can do is amputation, which is to remove part of all of a limb, and along with the tumor. So in the past, amputation was the main way to treat bone cancers found in arms and legs. Osteosarcoma, especially in our student days, we used to remember, if you diagnose osteosarcoma, if the patient survives for more than 6 months, it means that your diagnosis is wrong. Now people are surviving with osteosarcoma for years together. Sometimes even they get a cure. So limb salvage in malignant tumors is another important topic. So this is an X-ray. Can somebody read it? I think we are reaching 1 hour left. So this is a tumor which has osteolysis and osteosclerosis. The cortex is breached. The cortex, there is periosteal elevation, Codman's triangle positive, and you can see that in the MR also. And this is the lesion. And this girl had osteosarcoma of the distal femur. She had 3 cycles of chemotherapy, or adjuvant chemotherapy as it is known, and was referred from oncology for limb salvage. So at those times, this is about, I think, at least 12, 13 years ago. This is the girl who was walking before the surgery. She has on the left side, she has a swelling and a tumor. This is the various stages of this girl when she came for follow-up. she had a tumor at the biopsy taken from the anterolateral part of the this thing. This is what I said, that when you have a tumor there, then you are stuck, because you are going anteromedially and trying to isolate the vessels and all that. And then what we did was excise that along this thing was excised, and then it was along with the plastic surgeons that was grafted. So when you do a biopsy, this is the importance, that you have to do it well, or at least discuss it with somebody and then do it. And this is the implantation of the tumor processes and closure. And this is the child walking, and after just a few years after the surgery. And this girl, now she is an Ayurvedic doctor, and you know, she is a very good singer, and she was taking part in one of the this thing. So the definition of limb salvage is a set of surgical procedures designed to accomplish removal of a malignant tumor and reconstruction of the limb with an acceptable oncological function and cosmetic result. So the major changes happened after 1970. Till then, the thing was very poor, because we didn't have the advanced imaging or chemotherapy or the radiotherapy and improved surgical techniques. When all these came into being, we could now do the limb salvage procedure, and it is possible in up to 85% of cases. So earlier it was 10 to 20% 5-year survival rate before 1970. Now the 5-year survival rate is 65 to 75%. So every patient with tumor of the extremity should be considered for limb salvage if tumor can be removed with an adequate margin and the resulting limb is worth saving. So that is the condition now. You have to see whether somehow you can preserve the limb. The barriers to limb salvage is poorly placed biopsy incision, major neurovascular involvement, displaced pathological fractures, fungating and infected tumors, recurrence of malignant tumors, and inability to afford chemotherapy. Because chemotherapy has made a world of difference now for, especially for limb salvage. Anybody knows the 3-strike rule in limb salvage? Bone, nerves, vessels, and soft tissue envelope. These are the 4 things that are taken into consideration. And if 3 of these key components are involved, then limb salvage is probably not worth considering. And this is known as the 3-strike rule. The goal of limb salvage is to get a painless limb, functional limb, tumor-free limb, and a good psychological outcome. So you must do appropriate radiography to know the different things that we discussed so far. You must do a CT scan, and you must do a CT scan of the chest to rule out pulmonary metastasis, an MRI scan to find out the relationship of the vessels and the medullary extent of the tumor, because unless you know that, you cannot plan your resection site. And you can also use this to find out if there are any skip lesions. Skip lesions means lesions which are in the primary bone. In the same bone, you can have lesions in other sites of the same bone. And you must plan your surgical margin. Previously, it was about 4 centimeters away from the MRI margin of tumor. Now we take about 2 to 3 centimeters. That's enough, they say. PET scan is an investigation of choice for metastatic lesions with unknown primary lesion, and also to know as I said before, chemotherapy, the necrosis of tumor mass. That can be known very well with this. And of course, residual tumor and recurrence of the tumor. Reconstruction after excision would be either you can do arthrodesis or you can do endoprosthetic replacement like the one which you showed earlier. You can use osteoarticular allograft, and allograft prosthetic composites are available now, where the allograft is incorporated into the prosthetic component. And there is a rotation plasty surgery, which has gone out of flavor now. And you can use autoclave tumor bone to replace it. So resection is the most important, and then you can use any of those things. So in reconstructive surgery, I'll just go fast. It's a rotation arthroplasty. This is one of the patients, the only one probably we did in our institution. To you excise there, and then you fix this bone here and turn the foot 180 degrees and fix it like that. And then you have to use a prosthesis. The ankle joint will work as the knee joint because you have fused the knee joint. The ankle joint will work as the knee joint, and she can walk. The foot will be like this. The prosthesis is designed so that it has a this thing for the foot to go in, and here this is acting as a knee joint, the ankle joint, known as the Van Ness rotation plasty. There are newer treatments like targeted therapy. They target the molecular and genetic changes in the cells that cause cancer. And these are important where chemotherapy has not been very useful. So newer things are coming in, and some of these are imatinib. These is a targeted therapy that can block the signals from these genes like PDGFRA and PDGFRB. So these you can just know for information. Denosumab is another drug which has been used now. It's a monoclonal antibody that binds to a protein called rank ligand. And this is, the rank ligand is normally tells osteoclast to break down bone. But denosumab binds to it and action is blocked. So this is a subcutaneous injection. Side effect is, of course, osteonecrosis of the jawbone. Bisphosphonates is another drug which has been used in bone cancer now to stabilize the bone. So I think with that, I think we are finished. It's about 1 hour. So my message to you would be, as clinicians when you're practicing onco or bone tumors, is that you must make a clinical diagnosis, and then at each level of your investigation, you make a diagnosis, and then till you reach the biopsy. And that will help you to get a good function for your patients. If there are any particular questions?
Thank you, sir. Thank you, sir, for a wonderful session. We got a very good outline on malignant tumors.
I think specific tumors we can do some other time.
Yes, sir. Yes.
Okay, if there are no questions, then good night.
Good night, sir. Good night. Thank you.
Good night.
Good night, sir. Bye.